Welcome to Chapter 5, Diagnostic Considerations. This is the clinical heart of the series. Having built the immunology in earlier chapters, we now turn to the question every clinician faces at the slit lamp. A patient has intraocular inflammation. How do you classify it? Build a differential.
Here's the framing for the whole chapter. Uveitis isn't one disease. It's a diverse group of intraocular inflammatory disorders. It can be infectious or non-infectious, and it can be isolated to the eye or a window into a systemic condition. It remains a major cause of vision loss worldwide. The central challenge is that very different diseases can look nearly identical in the eye while demanding completely different treatments, so accurate diagnosis is everything. Our tools are a standardized vocabulary that describes where the inflammation sits and how active it is, a differential built from history, review of systems, targeted exam, and the pattern of inflammation, and finally, laboratory testing that is targeted to the individual patient rather than ordered as a reflex. Keep that last principle in mind. It recurs throughout the chapter.
Let's start with terminology. The uvea, or uveal tract, is the pigmented vascular layer of the eye, the iris, the ciliary body, and the choroid. The word itself comes from the Latin for grape, reflecting the dark purple look of the choroid. Now, technically, uveitis means inflammation of the uvea, but clinically we use it more broadly for intraocular inflammation that can also involve the vitreous, retina, and optic nerve. The single most important clinical sign is inflammatory cells in the aqueous or vitreous. That's what tells you inflammation is present. But be aware that some manifestations, like retinal vasculitis or macular edema, aren't obvious on exam and often need imaging to detect, so the eye can be more inflamed than it looks.
Before we go further, a quick boundary setting slide. Inflammation isn't confined to the uvea. It can strike neighboring ocular structures too. Inflammation of the cornea is keratitis, of the sclera is scleritis, of the extraocular muscles is myositis, and of the orbit is orbital inflammation, sometimes called orbital pseudotumor. Why mention these in a uveitis chapter? Because the diagnostic and therapeutic approach to these non-uveitic inflammatory diseases overlaps heavily with the approach to uveitis itself. So the reasoning skills you build here transfer directly to the whole family of ocular inflammation.
Here's a concept to internalize early. Uveitis describes inflammation, not a cause. It's a finding, not a final diagnosis. The inflammation may be non-infectious, often autoimmune or autoinflammatory, or it may be driven by an infectious organism. And either form can be confined to the eye or tied to systemic disease. When non-infectious uveitis stays limited to the eye with no identifiable cause, we call it idiopathic or undifferentiated uveitis. The job of the initial evaluation is to carefully pin down the anatomic location and clinical character of the inflammation, and multimodal imaging can help characterize and document how active it is. Nailing down where and what kind is the foundation everything else builds on.
This slide drives home the value of history. A detailed history and review of systems are essential for spotting clues to an associated systemic disease. From there, you examine the relevant non-ocular organ systems, guided by the review of systems, the ocular findings, and your differential. Additional testing should be targeted to that clinical picture, not ordered indiscriminately. Labs can help establish an etiology, but they never replace a thorough history and systemic review. And the stakes are real. An incomplete or poorly directed workup can delay diagnosis, lead to inappropriate treatment, and worsen both ocular and systemic outcomes. In uveitis, careful thinking up front protects the patient later.
Let's put some numbers to the problem. Uveitis is a major cause of visual disability. It accounts for roughly 10% of blindness in the United States and Europe, and possibly up to 25% worldwide. Prevalence varies widely by region, about 58 to 121 cases per 100,000 in the US, but reported as high as 730 per 100,000 in the developing world. Anatomically, Anterior uveitis dominates, about 70 to 80% of cases, followed by panuveitis, posterior, and intermediate. And a few demographic patterns: a slight female predominance overall, peak incidence between about 20 and 60 years of age, with rising risk after 65, and uveitis is roughly 5 to 10 times less common in children than adults.
Geography shapes uveitis in ways that matter at the bedside. Developing countries see higher rates of infectious uveitis and of posterior and panuveitis, and several specific diseases cluster regionally: birdshot chorioretinopathy in Western Europe, Behçet disease in Turkey and China, and tuberculosis-associated uveitis in India. The practical lesson is that a patient's geographic origin and travel history are genuine diagnostic data. Where someone is from or has been can move a disease up or down your differential before any test is ordered.
To communicate clearly and study disease consistently, the field needed a common language, and that's the SUN system, the standardization of uveitis nomenclature, introduced in 2005. SUN classifies uveitis primarily by the anatomic location of inflammation, with added descriptors for onset, duration, and clinical course. Beyond anatomy, uveitis can also be categorized by whether it's infectious or non-infectious, and by whether or not there's an associated systemic disease. Think of SUN as the scaffolding for the rest of this chapter. Nearly every clinical description we use hangs off it.
Here are the 4 anatomic categories at the core of SUN: anterior, intermediate, posterior, and panuveitis, defined by where the inflammation predominates. 2 subtle rules are worth memorizing. First, if there are both anterior chamber and vitreous cells, but the vitreous inflammation is more than you'd expect for isolated anterior uveitis, you classify it as combined anterior plus intermediate, not panuveitis. Second, and this is the big one, posterior uveitis and panuveitis require actual retinal or choroidal inflammatory lesions. That distinction, real chorioretinal inflammation versus secondary complications, comes back several times, so lock it in now.
This table, Figure 5.1, lays out the SUN anatomic scheme side by side. Read it in 3 columns: the type, its primary site of inflammation, and the terms it includes. Anterior uveitis is centered on the anterior chamber and covers iritis, iridocyclitis, and anterior cyclitis. Intermediate uveitis is centered on the vitreous and includes pars planitis and posterior cyclitis. Posterior uveitis is centered on the retina or choroid and covers focal, multifocal, or diffuse choroiditis, chorioretinitis, retinitis, and neuroretinitis. And panuveitis, at the bottom, involves the anterior chamber, vitreous, and retina or choroid together, with no single site predominating. Use this table as your anatomic reference for everything that follows. Beyond location, the SUN system also standardizes the language of activity and time. It gives us agreed terms for onset, duration, and course, for grading how active the inflammation is, and for monitoring change over time, so that a 2+ cell reaction or a chronic course means the same thing in every clinic and every trial. And SUN keeps evolving. In 2021, it added formal classification criteria for 25 specific inflammatory diseases, moving the field from description towards standardized diagnosis. Let's run through the standardized terms. These tables on the right summarize the standardized SUN terminology we use to describe uveitis. Starting with onset, inflammation can be either sudden or insidious. Duration refers to the length of an individual episode. Limited disease lasts less than 3 months, whereas persistent disease lasts longer than 3 months. The course describes the overall pattern over time. Acute uveitis has a sudden onset and limited duration. Recurrent disease consists of repeated episodes separated by at least 3 months of inactivity without treatment. Chronic uveitis is persistent inflammation that relapses within 3 months after treatment is stopped. The bottom table standardizes how we describe changes in inflammatory activity. Inactive means 0 anterior chamber cells.
Worsening activity is a two-step increase in inflammation or progression to grade 4+, while improved activity is a two-step decrease or improvement to grade 0. Finally, remission is a much stricter term. It requires inactive disease for at least 3 months after all treatment for the eye disease has been discontinued.
Now, we walk through the anatomic types, starting with anterior uveitis, inflammation predominantly in the anterior chamber, usually arising from the iris and ciliary body. The vocabulary matters here. Iritis is inflammation confined mainly to the anterior chamber and iris. Iridocyclitis extends cells into the retrolental or anterior vitreous. Keratouveitis is corneal inflammation with secondary anterior chamber involvement. And sclerouveitis involves both sclera and uvea. And when multiple structures are involved, you name the primary site first. Severe or chronic disease can cause complications like corneal edema, band keratopathy, iris abnormalities, cataract, macular edema, and disc swelling. But here's the recurring rule. Those posterior complications, even macular edema, do not make this posterior uveitis or panuveitis. That reclassification requires actual retinal or choroidal inflammatory lesions.
Intermediate uveitis is defined by inflammation most prominent in the vitreous cavity. That vitritis can arise from the ciliary body, the pars plana, the retinal vasculature, or the peripheral retina. Typical findings are vitreous cells and haze, cellular debris, and peripheral or diffuse retinal vascular leakage, with macular edema being the most common structural complication. Severe or chronic disease may lead to peripheral tractional or exudative detachment, retinal neovascularization, cataract, or retrolental membrane. One important subset to know is pars planitis, a form of intermediate uveitis defined by peripheral preretinal collections of inflammatory and exudative material with no associated infection or systemic disease. So pars planitis is by definition the idiopathic version.
Posterior uveitis is inflammation primarily of the retina and choroid. Inflammatory cells may appear diffusely in the vitreous, overlying areas of active chorioretinal inflammation, or along the posterior vitreous face. On fundus exam, you might see focal, multifocal, or diffuse retinitis, choroiditis, and often associated retinal vasculitis. An important caveat: different posterior diseases can look alike, though some patterns are highly characteristic or nearly pathognomonic, which is why lesion morphology becomes such a useful diagnostic tool later. Secondary complications like macular edema, epiretinal, or choroidal neovascular membranes can occur, but same rule again, those alone don't classify disease as posterior uveitis. You need genuine retinal or choroidal inflammatory lesions.
Panuveitis is inflammation involving all the major compartments, anterior chamber, vitreous, and retina or choroid, with no single site clearly predominating. It can accompany either infectious disease or non-infectious systemic inflammatory disease. The key distinction, and you'll recognize the theme by now, is to separate true panuveitis from isolated anterior or intermediate uveitis that merely has secondary posterior complications. True panuveitis requires actual posterior segment inflammatory involvement, not just downstream effects like edema. That single rule prevents a lot of misclassification.
Retinal vasculitis deserves careful definition because the word is easy to misuse. It means retinal vascular abnormalities occurring in the setting of ocular inflammation. Here's the plain language distinction. Vasculitis means the vessels are inflamed, whereas vasculopathy means the vessels are damaged or abnormal, but without visible inflammation. Same looking plumbing problems, but only one has active inflammation driving it. On fluorescein angiography, vasculitis shows up as perivascular sheathing, vascular leakage, or occlusion. Two cautions. Peripheral vascular sheathing can occur in intermediate uveitis without making it posterior uveitis. And, importantly, retinal vasculitis is not itself a defining feature of any anatomic uveitis category. It's a descriptor that points towards specific diseases, which the next 3 slides catalog. When retinal vasculitis predominantly affects the arteries, a specific set of diseases rises to the top of the differential. Think of systemic lupus erythematosus, polyarteritis nodosa, and syphilis, the herpetic necrotizing retinopathies, acute retinal necrosis from HSV or VZV, and progressive outer retinal necrosis, and then Ivarn syndrome, Churg-Strauss syndrome, and Susak syndrome. You don't need to memorize the whole list cold, but recognizing that arteritis skews toward this group, infections, the connective tissue vasculitis, and the herpetic necrotizing retinopathies, helps you target the workup. When the vasculitis is predominantly venous, phlebitis, the differential shifts. Now think sarcoidosis, multiple sclerosis, Behçet's disease, birdshot chorioretinopathy, HIV paraviral syndrome, and Eales disease. A useful clinical anchor, sarcoidosis and multiple sclerosis are classic causes of retinal phlebitis, and Behçet is a can't miss because of its occlusive, sight-threatening course. So the artery versus vein pattern on angiography genuinely steers you toward different disease families.
And some diseases involve both arteries and veins. This mixed group includes ocular toxoplasmosis, relapsing polychondritis, granulomatosis with polyangiitis, Crohn's disease, and frosted branch angiitis, the last of which is itself a striking clinical picture of florid perivascular sheathing. Taken together across these 3 slides, the message is that characterizing vasculitis as arteritic, phlebitic, or mixed is a real diagnostic lever, narrowing a broad differential into a manageable shortlist.
Beyond anatomy, many uveitic diseases follow recognizable clinical patterns, and spotting those patterns narrows the diagnosis. Sun further characterizes uveitis by onset, duration, course, and severity of inflammation, and several other descriptors earn their keep clinically, whether disease is unilateral, bilateral, or alternating. The appearance, size, and distribution of chorioretinal lesions, and the morphology and distribution of keratic precipitates. In other words, the fine detail of how the inflammation looks and behaves is data. The next several slides unpack the most diagnostically useful of these features.
One of the oldest clinical dichotomies is granulomatous versus non-granulomatous uveitis, but it comes with a caveat. These are clinical descriptions, and they don't always match what you'd see under the microscope. Here's the intuition. Granulomatous refers to a particular chunky, organized-looking inflammation, classically with large, greasy deposits, while non-granulomatous looks finer and more diffuse. And crucially, the appearance can shift with the stage of disease, the antigen burden, and treatment, especially corticosteroids, which can make granulomatous inflammation look non-granulomatous. So use the label as a clue, not a fixed truth.
Let's define the granulomatous pattern. Histologically, it features epithelioid cells and giant cells. Clinically, look for large, often inferiorly clumped keratic precipitates and nodular or creamy deposits on the iris, in the vitreous, on the optic nerve, or in the choroid. The classic associations are the ones to have on instant recall: sarcoidosis, tuberculosis, Vogt-Koyanagi-Harada syndrome, and sympathetic ophthalmia. When you see big, greasy mutton fat precipitates and nodules, those 4 diseases should light up immediately.
The non-granulomatous pattern is the counterpart. Histology typically shows lymphocytes and plasma cells rather than epithelioid and giant cells. Clinically, the keratic precipitates are smaller and more diffusely distributed without prominent uveal deposits. 2 nuances keep you honest. Viral anterior uveitis can appear either granulomatous or non-granulomatous, so it straddles the divide, and lens-induced uveitis may show a zonal granulomatous pattern. So while the dichotomy is useful, several important entities refuse to stay neatly in one box.
Now we shift from how uveitis is classified to how it actually feels to the patient. The key principle for this short section is simple. Symptoms vary with the anatomical location, the speed of onset, the duration, the clinical course, and the underlying cause. The same disease category can whisper or shout. Let's take the symptom profile, location by location. Anterior uveitis has a wide symptomatic range, from an asymptomatic white eye to a painful red eye. Acute anterior uveitis classically causes eye pain, redness, photophobia, and blurred vision. That pain is typically ciliary spasm from iris inflammation, and it can radiate along the trigeminal distribution. Elevated pressure from angle closure or trabeculitis can add to it. But here's a critical exception. Chronic anterior uveitis, especially in juvenile idiopathic arthritis, can be completely asymptomatic, which is exactly why those children need screening exams rather than waiting for complaints. In chronic or severe disease, vision loss comes from band keratopathy, cataract, and macular edema.
Intermediate uveitis usually presents with a white, quiet eye, little redness or pain to tip you off. The common symptoms are floaters and blurred vision. The floaters are shadows cast by inflammatory cells and debris suspended in the vitreous, and the blurred vision typically reflects either macular edema or vitreous opacities sitting in the visual axis. So intermediate uveitis is often a visual disturbance disease rather than a painful one, which can delay presentation. Posterior uveitis, like intermediate, is usually painless, but the visual symptoms can be rich and varied. Blurred vision, floaters, photopsias, scotomas, metamorphopsia, and nyctalopia. That vocabulary maps onto retinal dysfunction, flashing lights, blind spots, distortion, and night blindness. Vision loss occurs either when retinitis or choroiditis directly involves the macula or through secondary complications like macular edema. The takeaway? A quiet, white eye with prominent visual symptoms should push you to look carefully at the posterior segment.
Now to the objective signs, and it helps to tie them back to the underlying biology. Inflammatory mediators produce three characteristic findings. Vasodilation gives you ciliary flush, the ring of redness around the limbus. Increased vascular permeability lets protein leak into the eye, producing aqueous flare. And chemotaxis draws inflammatory cells into the aqueous and vitreous, giving the cellular reaction. All three reflect the same thing: breakdown of the eye's normal vascular barriers and the migration of cells into spaces that are normally clear. Keep that cause and effect in mind as we catalog the findings compartment by compartment. Let's inventory the anterior segment findings, because this is where much of the exam action is. The major ones are anterior chamber cells and flare, hypopyon, fibrin, carotid precipitates, iris nodules, iris atrophy or heterochromia, meiosis, anterior and posterior synechia, and pigment dispersion. Cataract and band keratopathy also occur, but note the asterisk. Those two are more typical of chronic than acute uveitis. We'll take the most diagnostically important of these, cells and flare, KPs, and iris findings, and go deeper over the next several slides, because their fine detail carries real diagnostic weight. This figure demonstrates flare grading using the slit lamp beam. On the left, panel A shows a healthy eye. The anterior chamber is optically empty, so as the beam crosses it, the light looks interrupted. You see it on the cornea, then it seems to skip the clear aqueous. On the right, panel B is a severely inflamed eye. Dissolved proteins scatter the light, so the beam appears continuous and solid all the way across. That's 4+ flare. The plain intuition is a movie projector beam in a dusty room. Clean air, and you don't see the beam. Fill the air with particles, and the whole shaft lights up. Flare is that beam becoming visible because of protein in the aqueous.
The key finding in anterior uveitis is anterior chamber cells and flare, and SUN specifies exactly how to grade cells, so everyone measures the same way. The technique, a 1 by 1 mm slit beam,
high power around 16 to 20 times, full illumination, the beam angled 45 to 60 degrees in a dark room. Then you literally count cells in that tiny bright box of light. The threshold to know? A grade of half plus requires at least one cell per high power field in each of the 4 anterior chamber quadrants. And keep the two findings conceptually separate. Cells are actual inflammatory cells floating in the aqueous, while flare is the haze from protein. Cells generally track active inflammation. Flare can linger.
The character of the anterior chamber reaction itself can hint at the underlying process. A serous reaction is predominantly protein leakage, mostly flare. A purulent reaction is neutrophils and necrotic debris and can settle into a hypopion. A fibrinous reaction shows dense fibrin or plasmoid exudation. Think of this sticky, clotting-type inflammation seen in HLA-B27 disease. And a sanguinoid reaction mixes inflammatory cells with red blood cells, which can appear as a hypopion with hyphema. So even the texture of what's in the anterior chamber is a diagnostic clue worth noting. Keratic precipitates, KPs, are collections of inflammatory cells deposited on the corneal endothelium, and describing them well pays diagnostic dividends. Characterize them 3 ways: by size, small, medium, or large; by morphology, fine, round, nummular, stellate, granulomatous, or mutton fat; and by distribution, diffuse, in an inferior triangle known as the Arlt triangle, or focal, often next to an area of corneal inflammation. Age matters too. Freshly formed KPs tend to be white and smooth, while older ones become crenulated and shrunken, pigmented, or glassy. So KPs carry information about both the type and the timeline of inflammation. 2 KP patterns are especially high yield. Mutton fat KPs are large and yellowish, classically signaling granulomatous inflammation. Recalled at sarcoid, TB, VKH, and sympathetic ophthalmia quartet. Small stellate KPs, often diffusely distributed across the whole endothelium rather than pooling inferiorly, point especially toward Fuchs' uveitis syndrome and herpetic anterior uveitis, and may come with corneal edema. And as a marker of chronicity, band keratopathy is associated with long-standing uveitis, particularly JIA-associated disease. So the KPs alone can shortlist your diagnosis before you look anywhere else.
This slit lamp photograph, figure 5-3, shows medium and small KPs on the corneal endothelium. Notice the scattering of discrete, pale, rounded deposits across the back of the cornea, seen here against the dark pupil. These are the smaller, more diffusely distributed KPs, typical of a non-granulomatous reaction, quite different in scale from the large, greasy deposits on the next slide. Use this as your visual reference for what a modest, non-granulomatous KP shower looks like at the slit lamp.
Contrast the previous image with this one. Figure 5-4. Large mutton fat KPs in a patient with sarcoidosis. See how much bigger, rounder, and greasier these deposits are. They genuinely resemble globules of fat. Large KPs like these signal a granulomatous disease process. So the moment you see this appearance, that granulomatous quartet, sarcoidosis, tuberculosis, VKH, and sympathetic ophthalmia, should move to the front of your mind. This side-by-side with the previous figure is the clearest way to internalize the small versus mutton fat distinction.
The iris can be a diagnostic map if you read it carefully. Findings include anterior and posterior synechia and several named nodules defined by location: Cope nodules at the pupillary margin, Busacca nodules in the iris stroma, and Berlin nodules in the angle. You may also see frank iris granulomas. Heterochromia, a difference in iris color, is a hallmark of Fuchs' uveitis syndrome, while stromal atrophy is characteristic of herpetic uveitis. So a nodule's position, a subtle color change, or focal atrophy each nudge you toward a specific diagnosis. The iris rewards close inspection. Intraocular pressure in uveitis is genuinely two-faced, and understanding why keeps you from being fooled. Often the pressure is low during active inflammation because the inflamed ciliary body makes less aqueous and because uveoscleral outflow increases. Less fluid in, more fluid out. But pressure can instead spike for several reasons. Inflammatory cells and debris clogging the trabecular meshwork, trabeculitis, classically herpetic, pupillary block with iris bombée, or secondary angle closure. So the same disease can produce either low IOP or ocular hypertension, depending on which mechanism dominates. The practical point, always check the pressure and interpret it in context, because a high pressure in a red, inflamed eye can itself be a clue, pointing you toward herpetic disease. Moving posteriorly, the hallmark of intermediate uveitis is vitreous cells and vitreous haze. The cells may be individual or clumped, and the haze comes from proteinaceous inflammatory debris. Importantly, haze can be absent even when cells are present, so the two were graded separately. Other findings include snowballs, which are clumps of inflammatory cells suspended in the vitreous, snow banks, which are exudative material laid over the pars plana, ciliary body detachment, retrolental membrane, and vitreous strands or traction bands. These are the structural signatures of vitreous inflammation, and the next slides show how we grade and interpret them.
Vitreous cells are commonly graded on a 0 to 4 scale by examining the retrolental space in a dilated eye. The technique uses a 1/2 mm beam focused on the anterior vitreous just behind the lens. There's a useful clinical nuance about what the cells mean. Cells trapped within established vitreous strands tend to represent older, burned-out inflammation, whereas cells floating freely in more liquefied, syneretic vitreous are more likely to reflect recent, active disease. One caveat worth knowing for exams and trials: the SUN system does not actually specify a formal vitreous cell grading scale. The well-known standardized scale came from the MUST trial.
Here's a subtle but important idea. Vitreous haze may actually be a better indicator of inflammatory activity than the cell count alone. Why? Think of cells as individual specks you can count, but haze as the overall fogginess of the vitreous, and fogginess often tracks active inflammation more faithfully. Haze is graded by how clearly you can see the posterior segment on indirect ophthalmoscopy. The NIH grading system, adopted by Sun, uses a 0 to 4 scale based on standardized fundus photographs. This matters beyond the clinic. Haze has been used in clinical trials, both as an entry criterion and as an outcome, where a 2-step improvement can count as a major treatment response.
This figure, figure 5-7, is the standardized reference set for grading vitreous haze, the images clinicians and trials calibrate against. Read it from clear to opaque. Grade 0 is a crystal clear view. Trace, or half plus, is barely detectable haze. Grade 1 shows a few opacities with mild blurring of the optic nerve and vessels. Grade 2, the nerve and vessels are substantially blurred but still visible. Grade 3, the optic nerve is still visible, but its borders are blurred and no retinal vessels can be seen. And Grade 4 is dense opacity that obscures the optic nerve head entirely. The progression is essentially how much the media fog erases your view of the disc and vessels. Let's define two classic intermediate uveitis findings precisely. Snowballs are rounded clumps of inflammatory cells floating within the vitreous. Snow banks are exudative inflammatory material draped over the pars plana, usually most prominent inferiorly. Activity changes their look. Active snowbanks appear fluffy or shaggy, whereas with inactive pars planitis, the pars plana becomes smooth, gliotic, or fibrotic, and those residual scars are no longer considered active snowbanking. The appearance of snowballs and vitreous strands can also vary by the underlying disease. So recognizing not just their presence, but their texture tells you whether the disease is currently active. When intermediate uveitis becomes chronic, a specific set of structural consequences can follow.
cyclitic membrane formation, secondary ciliary body detachment, hypotony, and vitreous tractional changes. Notice how these link together mechanistically. A cyclitic membrane and ciliary body detachment impair aqueous production, which drives the hypotony, while traction threatens the retina. This is why controlling chronic vitreous inflammation matters. The complications are structural and can be vision-threatening in their own right, independent of the original inflammation.
The posterior segment can show a broad array of inflammatory findings. These include retinal or choroidal inflammatory infiltrates, arterial or venous sheathing, perivascular hemorrhage, retinal detachments of every type, exudative, tractional, or regmatogenous, RPE hypertrophy or atrophy, atrophy or swelling of the retina, choroid, or optic nerve head, preretinal or subretinal fibrosis, and retinal or choroidal neovascularization. The common thread is that all of this stems from inflammatory or infectious involvement of the retina and choroid. It's a long list, but it's really the many downstream faces of posterior inflammation, and the following slides give you a vocabulary for describing the lesions themselves.
Describing chorioretinal lesions precisely is one of the highest yield skills in uveitis because morphology often points to a specific disease. Start with distribution. Are the lesions unifocal, multifocal, or diffuse? Then note size, color, morphology, and their relationship to posterior pole landmarks like the disc and macula. And read activity from the margins. Active lesions tend to have blurred, poorly defined edges, while inactive lesions become sharply demarcated and often develop pigmentation. That active versus inactive read from the borders is something you'll use constantly to decide whether disease is currently smoldering or old and quiet.
3 lesion shapes are worth committing to memory because their names map to classic diseases. Punched-out lesions are round with well-demarcated borders. Placoid lesions are large, flat, and gray-white, often patchy with indistinct margins. The word placoid literally evokes a broad plaque, and it should make you think of diseases like APMPPE. Serpentine, or serpiginous lesions, have sharply defined, wavy, snake-like borders and characterize serpiginous choroiditis. Learning to attach the shape to the pattern turns a fundus photo into a short list of diagnoses.
Now we pivot from the exam, the history, the engine of the differential. A comprehensive history and review of systems are essential for narrowing possibilities and guiding targeted testing. The relevant factors are broad: age and sex, genetic background, ethnicity, and geographic origin, personal or family history of autoimmune or infectious disease, immunocompromised state, sexual history, IV drug use, tobacco exposure, occupation, and diet and animal exposures. Each of these can flip the differential. An immunocompromised patient, a specific travel history, or an animal exposure can make a rare cause suddenly likely. The history is where diagnostic hypotheses are born.
A few more historical factors round out the picture: immunization history, current systemic medications, trauma, travel, prior hospitalization or surgery, indwelling lines or instrumentation, and existing medical conditions. Any of these can point to a specific infectious, inflammatory, or exposure-related cause. And 2 conceptual reminders that are easy to forget clinically. Uveitis can be an isolated eye disease or part of a systemic disorder. And critically, the ocular inflammation may not parallel systemic activity and can sometimes precede systemic manifestations entirely. In other words, the eye can be the first place a systemic disease announces itself, so a negative systemic review today doesn't close the door.
Let's frame the differential at the highest level. It falls into 3 major buckets: infectious uveitis, viral, bacterial, fungal, protozoal, or helminthic; non-infectious uveitis, presumed immune-mediated or autoinflammatory; and idiopathic or undifferentiated uveitis, where no specific cause is found. But there's a 4th category you must always keep in the room: masquerade syndromes, non-inflammatory conditions that mimic true intraocular inflammation. Forgetting masquerades is how a malignancy gets treated as uveitis, so they stay on the list until actively excluded. The next slide names the ones to fear.
These are the masqueraders, conditions that imitate uveitis but aren't inflammatory in the usual sense, and some of which are dangerous to miss. The neoplastic ones top the worry list: vitreoretinal lymphoma, retinoblastoma, leukemia, choroidal metastasis, malignant melanoma, and juvenile xanthogranuloma. Then the non-neoplastic mimics: pigment dispersion syndrome, retinal detachment, vitreous hemorrhage, retinitis pigmentosa, and ocular ischemic syndrome. The unifying lesson is that whenever a uveitis doesn't behave as expected, atypical age, poor treatment response, or an odd picture, you should consciously ask whether one of these masqueraders is the real diagnosis.
So, how do you actually narrow things down? A careful history and a precise description of the ocular findings are critical because certain patterns strongly suggest specific diseases. But stay humble. Classic presentations aren't always present, and findings evolve with time, disease progression, and treatment. When the diagnosis is unclear, fall back on systematic classification. Sort the inflammation by anatomical location, acute versus chronic, unilateral versus bilateral, adult versus pediatric, and any associated systemic or exposure factors. This pattern-based approach reliably narrows a sprawling differential down to the diseases that best match the patient's phenotype. The next slide turns it into a concrete algorithm.
Here's the practical 3-step algorithm. Step 1. Start with anatomic location: anterior, intermediate, posterior, or panuveitis. Step 2. Characterize the pattern: acute versus chronic, unilateral versus bilateral, mild versus severe, focal versus multifocal versus diffuse, vitritis, present or absent, and vasculitis, present or absent. Step 3. Layer in the associated clues: age, systemic symptoms, immune status, travel and exposure history, prior surgery or trauma, and any medication or instrumentation history. Location, then pattern, then clues. Run every uveitis patient through those 3 filters, and a manageable shortlist falls out. The following slides apply this exact framework, one anatomic location at a time.
Let's apply the framework to anterior uveitis, organized by pattern. In the acute or severe group, arthritis, back pain, or GI and GU symptoms point to HLA-B27 spondyloarthropathy. Oral and genital ulcers suggest Behçet. A febrile illness with renal symptoms raises Tinea, and recent surgery, trauma, or indwelling lines flag endophthalmitis or toxic anterior segment syndrome. In the moderate, painful, or atypical group, pulmonary or systemic findings suggest sarcoidosis. Blunt trauma, traumatic iritis, elevated pressure, herpetic uveitis, or glaucomatous-cyclitic crisis, and a poor steroid response should make you consider syphilis or another infection. And in the chronic, quiet group, a child with arthritis means JIA-associated uveitis, heterochromia with diffuse small KPs means Fuchs, and a post-surgical picture suggests low-grade endophthalmitis. Same 3-part logic, mapped onto real diagnosis. For intermediate uveitis, a handful of clues do most of the work. Pulmonary or granulomatous findings point to sarcoidosis. Tick exposure or erythema migrans suggests Lyme disease. Neurologic symptoms raise multiple sclerosis. Age over 50 with unexplained vitritis should raise vitreoretinal lymphoma. And when no systemic or infectious cause turns up, you're left with pars planitis, the idiopathic form. Here's the high-yield pearl, worth stating plainly. An older patient with persistent, unexplained vitritis is lymphoma until you've adequately excluded it. That single memorable rule will serve you far better than trying to recall an exhaustive list of tests, because missing a masquerading lymphoma has grave consequences. For posterior uveitis, let the lesion pattern lead, starting with chorioretinitis accompanied by vitritis. Among focal lesions, an adjacent old scar or raw meat exposure points to toxoplasmosis. A child with pica or geophasia suggests toxocoriasis, and an immunocompromised host raises CMV retinitis. Among multifocal lesions, pulmonary or systemic findings suggest sarcoidosis, TB endemic exposure, tuberculosis, peripheral necrosis with occlusive vasculitis, acute retinal necrosis, immunocompromise, syphilis or coxoplasmosis, IV drug use, candida or aspergillus, a visible parasite, cysticercosis or onchocerciosis, age over 50, vitreoretinal lymphoma, and no systemic clues at all, birdshot or multifocal chorioiditis. The presence of vitritis plus the focal versus multifocal split already carves the differential dramatically.
Now the remaining posterior patterns. For diffuse inflammation, dermatological or CNS findings suggest VKH, bilateral disease after trauma or surgery, sympathetic ophthalmia, a post-surgical or traumatic picture, endophthalmitis, a child with geophasia, toxocoriasis, and a warm climate with animal exposure, due sun. For chorioretinitis without vitritis, a history of carcinoma raises a neoplastic masquerade. Ohio or Mississippi River Valley residents, ocular histoplasmosis. A posterior pole white dot pattern, the syndromes APMPPE, Mudes or PIC. A serpiginous pattern, serpiginous choroiditis. And severe immunocompromise, porn. And for retinal vasculitis, aphthous ulcers with hypopyon means Behçet, malar rash and arthralgias, lupus, and sinus disease with pulmonary and renal findings, granulomatosis with polyangiitis. Whether vitritis is present and the lesion pattern, again, do the heavy lifting.
With the differential built, we come to testing philosophy, and this slide is really the ethos of the whole workup. The foundation is the history, review systems, a thorough ophthalmic exam, a focused systemic exam, and a working differential. Only then, after the inflammation is classified by anatomy and phenotype, should labs be ordered. There is no universal uveitis panel that fits every patient. Testing should be targeted to the most likely diagnoses, and many patients need only a few studies. A broad shotgun workup is expensive, hard to interpret, more likely to throw off incidental or false positive results, and can actively distract from the true diagnosis. Test the patient in front of you, not a checklist.
That said, a few tests earn near universal or frequent consideration. Syphilis testing is recommended in essentially all uveitis patients, and for good reason. Syphilis can mimic nearly any pattern of ocular inflammation, and missing this occult infection while treating with corticosteroids alone can have serious ocular and systemic consequences. Tuberculosis testing should be considered when clinically appropriate, and especially before or during systemic immunomodulatory therapy, since immunosuppressing a patient with latent TB is dangerous. And chest imaging can help evaluate for sarcoidosis in the right setting. So the rule is targeted testing, with syphilis as the notable near exception that's almost always worth checking. This slide distills the philosophy into a single pearl worth repeating. Test the differential, not the disease list. Use the history, the review of systems, and the ocular phenotype to generate your differential first. Then choose the specific labs and imaging that will rule in or rule out those particular diagnoses. Laboratory testing exists to support your clinical reasoning, never to replace it. If you find yourself ordering a test without a diagnosis it's meant to confirm or exclude, that's the moment to stop and think. This mindset is what separates efficient, accurate workups from expensive, confusing ones. Here's a concept that trips up even strong clinicians, so let's make it intuitive. Even a highly sensitive and specific test can mislead you when the disease is unlikely to begin with. Imagine screening thousands of low-risk people for a rare disease. Because the disease is so rare, Most of your positive results will actually be false positives, not real cases. The handful of true cases gets swamped by the errors. This is Bayesian reasoning. How you interpret a test depends not just on the test's accuracy, but on the pre-test probability that this patient actually has the disease. That's the mathematical backbone of everything we just said about targeted testing. Order tests where the pre-test probability is high enough for a positive to mean something.
Now to imaging, which serves double duty, both diagnosing uveitis and monitoring the response to treatment. These modalities can reveal what the slit lamp and dilated exam simply can't see, and multimodal imaging combines complementary tests to characterize inflammation more fully. Depending on the suspected disease, the toolkit includes OCT, fluorescein angiography, indocyanine green angiography, fundus autofluorescence, ultrasonography, and electrophysiologic testing. The take-home for this section: choose imaging based on the suspected site and mechanism of inflammation, and remember that it's often most powerful when several modalities are read together rather than in isolation. The next slides walk through each one.
OCT is the workhorse of posterior imaging in uveitis, a non-contact modality giving high-resolution cross-sectional images of the retina and choroid. It excels at identifying and objectively monitoring uveitic macular edema, retinal thickening, intraretinal and subretinal fluid, serous retinal detachment, chorioretinal lesions, and choroidal neovascularization. In fact, OCT is the reference standard for objectively assessing uveitic macular edema, which is exactly why it's so central to following treatment response over time. Its main limitation is media opacity, though useful macular images can sometimes still be captured even through poorly dilating pupils. If you monitor one thing with OCT in uveitis, it's the macula. OCT does more than image the macula. RNFL OCT, of the retinal nerve fiber layer, is useful for monitoring patients with uveitic glaucoma, tracking structural damage over time. Anterior segment OCT extends the technology to the front of the eye, helping identify retained lens fragments and IOL-related chafing, and it's particularly valuable in persistent post-operative uveitis, where a mechanical cause may be hiding. In looking ahead, OCT-based methods to objectively quantify intraocular inflammatory cells are under active investigation, potentially replacing subjective cell counts with a reproducible number. So OCT's role in uveitis is still expanding.
Enhanced Depth Imaging OCT, or EDI OCT, is a variation that pushes the imaging deeper, dramatically improving visualization of the choroid, a layer standard OCT struggles to see well. That makes it especially useful for detecting and monitoring choroidal structural changes in the diseases where the choroid is the main battleground: Vogt Koyanagi-Harada syndrome, sympathetic ophthalmia, and birdshot chorioretinopathy. In those conditions, following choroidal thickness with EDI OCT can be a sensitive gauge of disease activity and treatment response, catching change before it's clinically obvious.
Fluorescein angiography is a cornerstone for evaluating posterior uveitis and chorioretinal disease. After an intravenous injection of fluorescein dye, sequential images map the retinal vascular anatomy and perfusion, give some information about the choroidal circulation, and highlight areas of leakage and inflammation. FA is particularly useful for detecting macular edema, retinal vasculitis, retinal or choroidal neovascularization, optic nerve inflammation, and retinal and choroidal inflammatory lesions. And several of the white dot syndromes produce characteristic angiographic patterns that can clinch a diagnosis. Think of FA as your primary tool for interrogating the retinal circulation and where it's leaking. This late-phase fluorescein angiogram, figure 511, comes from a patient with sarcoidosis-associated anterior uveitis. Look at the macula. The dye has pooled into a radiating, flower-like pattern of bright spokes around the fovea. That's the classic petaloid pattern of inflammatory macular edema, fluid collecting in the spoke-like Henle fiber layer of the macula, which fills with dye and lights up as petals. This image is the angiographic signature of the most common vision-limiting complication in uveitis, and it shows why FA is so useful for detecting macular edema that may be subtle on exam. Standard angiography centers on the posterior pole, but disease often hides in the periphery, and that's where wide-field FA earns its place. It's particularly useful for identifying peripheral retinal vascular abnormalities, revealing vascular leakage or inflammation that routine exam and standard imaging can miss entirely. That makes it especially valuable for assessing the true extent of retinal vasculitis and peripheral inflammatory activity, sometimes showing that disease is far more widespread than the posterior pole alone would suggest. When you suspect vasculitis, going wide can change your assessment of severity. It's easy to overlook, but color photography is a genuine diagnostic and monitoring tool. Anterior and posterior segment photography gives objective documentation of inflammatory findings, recording lesion size, color, location, and morphology in a way that memory and hand-drawn sketches can't match. Serial photographs let you assess whether disease is progressing or regressing over time, and they're especially useful for establishing a baseline in relapsing remitting disease. Classic uses include documenting new posterior syncytiae in anterior uveitis, or capturing the transient posterior segment inflammation of Behçet's disease before it vanishes. A good photo is objective, shareable, and comparable across visits.
Fundus autofluorescence, or FAF, is a non-invasive technique that maps the natural glow of lipofusion within the RPE, no dye needed. Here's the intuition. The RPE naturally contains a pigment that fluoresces, so FAF essentially photographs the health and activity of that cell layer by how brightly it glows. It's especially useful in posterior uveitis involving the outer retina, RPE, and inner choroid. Bright, hyperautofluorescent areas can mean increased RPE metabolic activity, often more active inflammation, or a window defect where photoreceptors have dropped out. Dark, hypoautofluorescent areas usually means the RPE is lost or blocked, and you can watch disease evolve. As inflammation improves, hyperautofluorescent lesions may resolve or fade into hypoautofluorescence, signaling permanent RPE damage.
Indocyanine green angiography, ICGA, is the choroidal counterpart to fluorescein angiography. It also uses an intravenous dye with serial imaging, but its particular strength is the choroidal circulation, which it visualizes far better than FA, because the ICG dye, in its longer wavelengths, penetrate the RPE that tends to obscure the choroid on fluorescein. So in inflammatory disease of the outer retina and choroid, ICGA can reveal abnormalities that are more extensive than what you see on clinical exam or on fluorescein angiography. And those extra findings carry both diagnostic and treatment implications, sometimes revealing active choroidal disease that would otherwise go unrecognized. So when do you specifically reach for ICGA? It's particularly useful for choroidal neovascularization, the white dot syndromes, Vogt-Koyanagi-Harada syndrome, sympathetic ophthalmia, and posterior segment sarcoidosis, a list unified by choroidal involvement. Take, for example, this image on the right, which demonstrates numerous scattered hypocyanescent spots, which show up in the late phase of the ICGA, in a patient with birdshot chorioretinitis, marked by the black arrows. Here's the clean take-home that pairs the two dye studies. Fluorescent angiography is primarily a retinal vascular study, while ICGA is especially useful when the choroid is the major site of inflammation. Match the modality to the layer you're worried about. Retina? Think FA. Choroid? Think ICGA.
Ultrasound gives you two complementary tools. Ultrasound biomicroscopy, or UBM, is high-frequency imaging of the anterior segment, especially useful for the ciliary body, iris, and iridocorneal angle, and it can identify malpositioned IOL haptics. B-scan ultrasonography images the posterior segment and is particularly valuable when media opacity, a dense cataract or vitreous haze, blocks your view. B-scan can demonstrate vitreous opacities, choroidal thickening or elevation, retinal detachment, cyclitic membranes, and occult intraocular foreign bodies, and its findings can be highly suggestive or even diagnostic of posterior scleritis. And note, retained lens fragments can be picked up with either anterior or posterior segment ultrasound. When you can't see in, ultrasound lets you look anyway.
Electroretinography, or ERG, shifts us from imaging structure to measuring function. Full-field ERG provides an objective measure of global retinal function, essentially recording the electrical response of the whole retina to light. It's useful for monitoring birdshot chorioretinopathy, evaluating the AZOR complex disorders, diagnosing autoimmune retinopathy, and a key application, distinguishing a retinal dystrophy from posterior uveitis, since these can look similar but have very different implications. When the fundus doesn't fully explain the vision loss, or you need to know how the retina is actually performing, ERG provides that functional readout.
Visual field testing is another functional tool with several uveitis roles. Kinetic and static perimetry can monitor disease progression and treatment response in birdshot chorioretinopathy and the AZOR complex disorders. Fields are also valuable for tracking uveitic glaucoma and inflammatory optic neuropathy or optic neuritis, where they quantify functional loss over time. And microperimetry adds a finer capability, localized functional assessment of the macula, which can be useful in macula-involving inflammatory diseases, such as punctate inner choroiditis. So perimetry rounds out the picture by measuring the vision the patient is actually left with.
When imaging and serology aren't enough, we can sample the eye itself, and PCR is the star of intraocular diagnostics. PCR testing of aqueous or vitreous is highly sensitive and specific for many causes of infectious uveitis. Its great advantage is that it can amplify a pathogen's DNA from a tiny volume of intraocular fluid, perfectly suited to the small samples the eye allows. And its usefulness isn't limited to infection. PCR-based genomic testing can also assist when vitreoretinal lymphoma is suspected. So a few drops of ocular fluid can carry a remarkable amount of diagnostic information. Which fluid should you sample? Anterior chamber paracentesis is generally easier and safer than vitreous sampling, so it's often the first choice, but yield depends on the clinical scenario. In herpetic posterior uveitis or acute retinal necrosis, aqueous and vitreous PCR are often similarly informative, so the safer aqueous tap makes sense. In viral anterior uveitis, aqueous PCR may be less sensitive, especially when inflammation is minimal at the time of sampling. And in toxoplasmosis, aqueous PCR tends to be less useful than vitreous unless the patient is immunocompromised or has large or multifocal lesions. So match the compartment you sample to the disease you suspect. Standard PCR looks for one specific organism you already suspect. Broad-range PCR is cleverer. It can detect whole categories of bacteria or fungi at once. Here's how, in plain terms. Certain genes are shared by essentially all bacteria, or all fungi, with tiny species-specific differences. Bacteria share their 16S ribosomal sequences. Fungi share their 5.8, 18S, and 28S ribosomal sequences. By targeting those universal genes, you can run a pan-bacterial or pan-fungal test rather than guessing a single culprit, casting a wide net instead of a single hook. And the yield can equal or beat traditional intraocular fluid culture. It's especially valuable when you know there's an infection, but not which organism. PCR is powerful, but respect its limits. A negative PCR does not fully exclude infection when clinical suspicion stays high, so repeat aqueous or vitreous sampling can be worthwhile, ideally during more active inflammation or after antimicrobial therapy has stopped. The specific limitations to keep in mind are cost, the small sample volume, which caps how many tests you can run, contamination causing false positives,
and false negatives when little pathogen or cellular material is present. The take-home: PCR is most useful when it's directed by a strong clinical suspicion and when you sample the correct ocular compartment at the right time. Aimless PCR disappoints. Targeted PCR excels.
Despite the rise of PCR, culture and staining remain important, particularly when bacterial or fungal endophthalmitis is suspected. Their advantages are practical. Culture and bacterial or fungal stains are widely available, relatively inexpensive, and traditionally the first-line microbiological test. The limitations are that culture is time-consuming, and its sensitivity drops when the organism burden is low. But here's why culture still matters, even in the PCR era. It can directly identify the causative organism, and crucially, provide the antimicrobial susceptibilities that guide treatment, something a DNA amplification test alone doesn't give you. So culture and PCR are partners, not rivals.
When the concern is infiltrative or neoplastic disease rather than infection, cytology and pathology take center stage. Aqueous cytology can help diagnose infiltrative or neoplastic processes involving the anterior segment, including leukemia and lymphoma. And when vitreoretinal lymphoma is suspected, recall that older patient with stubborn vitritis, an undiluted vitreous specimen should be sent for a full panel: cytology, flow cytometry, gene rearrangement studies, and cytokine analysis. That multi-test approach maximizes the chance of catching lymphoma cells, which are notoriously fragile and easy to miss on a single test. Handling and processing the specimen correctly is as important as obtaining it.
Chorioretinal biopsy is the most invasive diagnostic step, technically challenging and reserved for carefully selected cases. Consider it when you face rapidly progressive, vision-threatening posterior uveitis. No diagnosis despite an extensive workup, a poor response to empiric therapy, suspected subretinal vitreoretinal lymphoma with minimal vitreous cells to sample, or a negative vitreous biopsy despite persistent concern for lymphoma. The common thread is a serious, undiagnosed, sight-threatening process where less invasive testing has failed, and the answer is worth the surgical risk. It's a last resort, but sometimes a vision-saving or even life-saving one.
Biopsy isn't limited to the retina and choroid. A directed conjunctival biopsy can be useful for lymphoma, cicatricial pemphigoid, and sarcoidosis. Scleral biopsy is rarely required, but may be considered when an infectious cause of scleritis is strongly suspected. And an important strategic principle: when systemic disease is suspected, biopsying an accessible non-ocular site is generally preferred when possible, because it usually offers higher diagnostic yield with lower morbidity than a vitreous or chorioretinal biopsy. In short, if there's a safer window into the same disease process elsewhere in the body, take it before you biopsy the eye.
Diagnostic anterior chamber paracentesis may be performed at the slit lamp or with the patient lying supine. In this example, an assistant is positioned temporally and stabilizes to the patient's face to withdraw the syringe as shown in this still. After obtaining informed consent and final verification, the lids are cleaned with povidone iodine 10%. A lid speculum is placed, and a drop of 5% solution is applied to the ocular surface. Using a bevel-up 30-gauge needle on a 1 cc syringe and a cotton tip for countertraction, the anterior chamber is entered temporally, parallel to the iris plane. In phakic patients, risk of inadvertent lens touch is reduced with a non-dilated pupil and an entry point in the superior or inferior limbus. The 9 o'clock position was used for this pseudophakic patient. The assistant withdraws an aliquot of aqueous fluid while the surgeon maintains continuous direct visualization of the needle tip. Other techniques allow free flow of aqueous into a plungerless syringe. Between 100 and 200 microliters may be withdrawn, or just to the point of corneal dimpling.
Hello. In this video, we plan to demonstrate the techniques involved in performing a pars plana approach to chorioretinal biopsy. Initially, a complete vitrectomy is performed. Following vitrectomy, laser barricade is applied around the area of the intended chorioretinal biopsy. After complete barricade has been achieved, a 33 gauge subretinal cannula is used to pierce the retina. Fluid is infused underneath the retina, raising a small bleb of retinal tissue. Endodiathermy is applied to the small retinal vessels in the area of the planned incision in an attempt to reduce bleeding during that phase of the procedure. A vertical intraocular scissor is used to cut the retina. Intraocular forceps are then used to retrieve the excised portion of the retina. In this case, we elected also to perform a choroidal biopsy. Again, endodiathermy is applied in the area of intended incisions in the choroid in an attempt to control bleeding. Vertical intraocular scissors are used again, but this time to cut the choroid. Again, intraocular forceps are used to retrieve the portion of excised choroid. Here is what the retina and choroid look like after the excisional biopsy. At this point, an air fluid exchange and silicone oil were injected to complete the case.
Our final content slide covers diagnostic vitrectomy and both its risks and a key pharmacological twist. The potential complications in uveitic eyes include retinal tears or detachment, suprachoroidal or vitreous hemorrhage, worsening cataract, increased intraocular inflammation, and rarely sympathetic ophthalmia. Importantly, vitrectomy can serve both diagnostic and therapeutic roles in selected cases. But here's a consequence that's easy to forget. Vitrectomy significantly alters the pharmacokinetics of intravitreal medications. With the vitreous gel removed, intravitreal drugs clear more rapidly, and in particular, the half-life of intravitreal corticosteroids is shortened in vitrectomized eyes. So a steroid injection may not last as long after vitrectomy, which directly affects how you dose it.
That brings us to the end of Chapter 5. We've moved from what uveitis is and how it's classified through the Sun framework and the anatomic types, into the symptoms and signs, the pattern-based differential, and finally the targeted use of labs, imaging, and tissue sampling. If you carry away one principle, let it be this: classify the inflammation carefully, build a differential from the pattern, and then test that differential rather than reaching for a reflexive panel. Precise observation and disciplined reasoning are what turn intraocular inflammation into a diagnosis. Thank you.